while our standard care controls only reduced theirs by 12. So it's more than double the amount of improvement. And here you can see scores on the multidimensional fatigue symptom inventory. I have a wonderful, very, very wonderful postdoc who is now a junior faculty member with me who did some initial mediation analyses, and she actually was able to show that 22 to 37% of the yoga effect on fatigue is contributed by improving overall sleep quality, but the key one, the one that had 37%, was reducing daytime naps. So all I had to do was have them do some yoga, most of the time in the evening, after work before dinner. It reduced their daytime napping, which if you're a sleep specialist, you know means it primes your pump, you're more likely to sleep and sleep more efficiently and throughout the night, and that's exactly what we're seeing. There's no drug, by the way, that can even touch these percentages. So those of you who may or may not have seen my featured article in JAMA Oncology that says the only thing going in the world right now for fatigue is exercise. It's better than any drug we have on the market. And that was a huge meta-analysis. We also were able to show that it improved daily activities and quality of life. Two of them that I'm reporting here is, so the green going down means that you have less impairment, because the question is asked how impaired is your walking and general physical activity. So we see walking, general physical activity, overall quality of life. And here now we looked at changes in sleep on fatigue, but we were interested in changes in fatigue on quality of life. And again, Dr. Lin was able to show 45% of the effect of yoga on overall quality of life was contributed by improving fatigue. We showed that it significantly improved anxiety and mood. And the other part that's really important about this is you can have improvements, but it can be teeny tiny. Okay, and teeny tiny can be statistically significant but not mean a thing to a patient. And what we found is that our improvements were big, 18%, 45%. These are clinically meaningful improvements to a patient in real life. So one of my other junior faculty mentees was really interested in what went on in terms of aromatase inhibitors and those on tamoxifen. So he wanted to look at the muscle aches and pains or the arthralgias that are associated with that, and you can see what he found, that the yoga provided significant reductions in muscle aches and pains in both groups, women on aromatase inhibitors and tamoxifen. He also found the same thing with respect to reducing overall pain. A third junior faculty member of mine looked at the influence, who was very interested in cognitive impairments among breast cancer patients going through treatment, looked at the influence of yoga on memory difficulty. And again, she showed that the memory impairment that is experienced by breast cancers, which is often referred to as chemo brain, very big deal these days that we're looking for treatments for, yoga was very helpful there. And then some of the other things that we began looking at in this work, and I used accelerometry in order to do this, was to look at how yoga changes circadian profiles. And for those of you who, you probably heard about circadian rhythm in your body, right? And we do have a circadian rhythm. It's controlled by the suprachiasmatic nucleus. You have these output rhythms that we think about, which are physiological, cellular, at the cellular level, they're behavioral. And these are some of the examples. You often think of eating and sleeping, but I'm sure those of you that work in kinesiology, you think about moving and circadian rhythm too, right? It's the second strongest perturbator of the entire circadian rhythm system out there next to light, okay? So you want to do something to affect your circadian rhythms, you want to affect your cell cycle regeneration, you want to affect your hormone releases, all these things, your inflammatory profiles. Even more recently, I'm working with an amazing genetic, molecular geneticist, and we're looking at circadian clock correlations of all the circadian genes and the signatures at moments and times throughout the day to see if they are normal or abnormal in terms of that. So what we saw in our first study with actigraphy, where we measured it through behavioral patterns in physical activity, was that our yoga participants actually showed more regular circadian patterns, which were indicative of patterns that elevated when they were supposed to, and decreased when they were supposed to, versus patterns that were irregular, which were blunted. So you would see this blunting where it would stay down low and then go up, and then it would stay up and go down way too late. Those patterns we saw in the controls look exactly like the patterns that were seen by like David Spiegel and some others out of California using cortisol and melatonin. And it's not only indicative of problems with the breast cancer, it's indicative of death when that is dysregulated. So we are very happy to see that the yoga actually regulated this profile and made it stronger. So we have a lot of overall benefits from yoga in this study. The list is a mile long from the 2 studies. It's work that I am thrilled about. It's work that caused me to actually, at one point, be invited to India by the Prime Minister to serve on a board for him to talk about, and this will be interesting. So when you think about paradigm shifts in the way that we do medicine and operate in the medical world in our sort of Eastern European way of thinking, or Western European way of thinking, right? And then you think about Eastern countries like India and stuff like that, and the differences in the way we practice and believe in medicine, okay? When I started doing this work, anything, even exercise, traditional walking and running was called complementary and alternative medicine, right? And now, that's dirty, we don't call it that, we want to call it integrated medicine because we've spent decades showing that this stuff works, and now our Western European way of thinking wants to adopt it, so it's now integrated, not alternative, right? But what's interesting to me is we're adopting this stuff so rapidly in the United States, right, and Europe. And when I went to India, at the request of the Prime Minister, I found out, I thought I was going to walk into India and they are going to be implementing it. So in a country where there's only 80% of people have no healthcare coverage whatsoever. They have no way to treat them. They're literally camping on the sidewalks under tarps to hope that some doctor will stop and give them something to help them. And when I went there, I thought, oh, I'm going to go to the heart of yoga, the birth of yoga. This is going to be great. I'm going to learn so much, and I'm going to learn how to apply it in cancer. And I walked into the cancer hospitals, and they were saying, oh, we don't do that here. And I'm talking to all doctors who have been trained in U.S. medical schools, who've gone back to India to practice. And all of this rich history that can be so helpful is being poo-pooed and pushed to the side. So the Prime Minister said, no, we're not going to have that happen. We're going to bring the Ayush therapies back into the work we're doing in the cancer centers. And so that's how I ended up having the opportunity to work with their big medical school there, and we're going to implement an exercise oncology program, and it's going to involve yoga. I'm working with several cancer hospitals. I'm working with a yoga therapy university, several Ayurvedic hospitals. It's quite exciting and fun to do. It's hard work. It's not easy to do it, but I'm optimistic that we'll get there. So lots of wonderful things. So what should we tell people? Tell them to try gentle hatha and restorative yoga. Not just my work, but that's what most of the work in yoga has studied to date. We want all 3 postures, not just one, or all 3 components, not just one. Average dosing, 60 to 75 minutes. We found they needed to do about 3 sessions a week, so the 2 in person and a little bit of home practice. Low to moderate. What do we recommend for exercise professionals, oncologists, and medical providers? Provide information regarding the benefits of yoga for managing cancer-related toxicities to all your patients. Refer them to qualified yoga instructors who have special training and experience working with cancer survivors. They're out there, they're plentiful, you can find them. If you need to learn how to refer patients to them, we can help you. And then to the survivors, and even patients during treatment, we say, because that term is encompassing both, we say yes to yoga, but choose wisely. Start gently, progress slowly, and practice safely. And then work with qualified yoga instructors, be aware of any contraindication you may have, use props, and make modifications for safe and effective yoga practice. These are sort of the take-home lessons of all of this. And one of the other things that I will say is there's a lot of misconceptions about yoga. And when I think back to my time as an exercise scientist, and I think about competing as a competitive gymnast and athlete, and then coaching, one of the things I love about yoga is that it flips the paradigm of taking your body into a gym and putting it into some mechanical pieces of equipment and pushing and pushing and pushing. You know, the old pain, no gain. You know, you go in and you're pumping iron and you're doing this. It's a very, very sort of patriarchal way of thinking about using the body for physical exercise, right? Yoga, actually, true practice of yoga comes at the entire way of thinking about a practice of movement 100% differently. It actually teaches you to listen to your body, to pay attention to your body, to explore the ways that your body can move, to take your body through range of motion and to hold it at the edge of a range of motion, to see if it's comfortable to push it a little more or not push it more, to pay attention to an injury, to learn how to think about that, to use the movement as a way to work with your thoughts and your feelings and your emotions, and to have those mental health benefits, not just whether or not your bicep is going to get big and round and like look like a little bubble, right? So I love yoga for that reason, because I feel like yoga at the heart of it is a very maternal, a very feminine approach to movement and therapy. So with that, I have to acknowledge all my collaborators. And again, one of the things that I will say really from my heart is I would not have the privilege of having the impact that I am able to have in this country and the world on the lives of cancer patients if it wasn't for UNCG allowing me to do my degree. And I could not be more grateful. And I hope I do you proud. Thank you.
We've got about 10 minutes for questions, so questions for Karen.
So tell me about the follow-ups. So like the 3 and 6 months, how many of the yoga people kept doing yoga even after they weren't required to do it?
We're still analyzing that data in the trial, so I can't answer that question directly, but the preliminary stats from my statistician, he just keeps telling me, this looks really good. So I haven't gone over the report with him yet on that. Our primary outcomes were the pre-post, so the 3 and 6 months was like our fourth secondary outcome. So as you know about clinicaltrials.gov and publishing papers and all the work it takes to do that, you methodically work through each and every one of these. So the 3 and 6 months, we're moving into that as we speak.
So for the mindfulness component, did you collect any data on perceived stress measures of the participants?
So when you say perceived stress, can you clarify that a little more?
So there's a perceived stress scale, and it asks about the individual's perception of stress in their life, and how they rate them.
Yes. So stress is also like considered a sort of a broad term in many ways, and oftentimes in clinical trials it's operationalized much more specifically. So for example, how does that stress show up? So we didn't ask global questions about stress, but we did ask on our symptom inventory, we have some more global questions that ask things about like worry in the global piece. But we get more specific, so I have very specific measures where I'm looking at actual anxiety in this trial. I look at depressive states, I look at mood. So this, you know, when you operationalize stress, you drop down to those next levels, and it's like, well, what is it exactly that you're getting at? So in our world, we back away from a lot of those global measures because we're trying to pinpoint the actual how it really shows up in a person. So I didn't ask global questions, but I asked specific questions of those domains. We have lots of validated questionnaires in the data. And you saw in the first trial, it was very helpful for overall, you know, anxiety, mood disruption. And in this trial, again, we haven't analyzed those questionnaires yet for that part. The second trial, by the way, the 3-arm trials is really fairly new data. It's not published yet, so you're seeing stuff before it's actually really out there fully.
I have lots of questions, and they probably overlap, and I'll just take a stab at a few of them. So I'm a yoga therapist, and so when I'm looking at this impressive work that you are doing, how did you design the practice? Who designed the practice? Did it have any specific protocol as far as what you are covering, as far as certain pranayamas or certain asanas? Do you have people in your classes, participants who are at different stages of their cancer treatment, of their cancer past recovery? Those are all the questions in my head. And when you are encouraging them to, you know, ideally it is great to have 2 practices a week and go home and practice a 3rd time. And I totally believe in that, and I give my students homework all the time. Did you do it in any specific formal way? Like, did you give them a handout? Did you give them a DVD? Did you give them any kind of...
Yeah, I probably skipped over that pretty quickly. So my yoga consultant is a cancer survivor herself,
Right.
who helped me design, and a very, very experienced yoga teacher and therapist. Okay, and so Margaret, she helped me design the yoga intervention. We specifically designed the yoga intervention in the 75-minute session to combine both the hatha and the restorative. And we went back to the ancient text to look at which asanas were supposed to work for sleep in the gentle hatha yoga. And so we took them in the first part of the class. And then what we decided to do in the second part of the class, because theoretically I was trying to think like a behavioral scientist to see if this would work. And I said, well, what if we emulated a circadian rhythm? And we brought them up for the first 45 or 75 minutes, and then we took them down. So it looks exactly like this. What if we created that rhythm in that 75 minutes? No one had done that in a yoga class, right? There weren't these combination classes yet in all the gyms and stuff.
Right.
So we did that, and that's how we put it together. So we put the gentle hatha. There's 16 different postures that they do throughout. Specific breathing, specific mindfulness. The participants got a yoga kit, which included a manual. It included a DVD that they could use and watch at home. And on the DVD, it had a 75-minute session. They could follow a 15-minute session and a 5-minute session. It had every asana explained. Every asana had 2 modifications explained for it that they could watch on the DVD.
Wow.
And they could take it home. So they could just pop it in and play it, right? And now, fast forward now, and I'm actually creating an online yoga app where it's only for cancer survivors using all of this data, where they can actually go online. We're going to put it on something like a Roku platform rather than a little like device. So you're going to be able to plug in your Roku, go to the store, boom, pop it up, and there's your yoga. And it will be specifically all our content for cancer patients. What else did you ask me? Did I answer it all?
You did. The participants at different stages of their...
So everyone in these trials were coming off what we call primary curative intent treatment. They were right at the end of it and just going right into it. There's some people now who've done some work with different kinds of yoga during treatment. It looks different than my protocol. My protocol would not fly in the middle of chemotherapy. You'd have to do something a little different. Probably not even in the middle of radiation. Maybe on maintenance therapy, which some of them were trained. At the time we were doing the first study, maintenance therapy consisted of aromatase inhibitors and tamoxifen. Now maintenance therapy consists of a lot of different things. And I do think all throughout maintenance therapy you would be able to do this.
Gotcha.
Yep.
Thank you.
So I have another question. So in looking at your centers throughout the U.S., I noticed 3 particular states, and I'll tell you why I noticed those states that don't have a center, or if they do, it's only one. And I'm from Alabama, so that really caught my attention.
Yep.
Do you know why, or is that because of an acceptance of what you're offering?
It is not because of anything that we do. So those green dots and red dots have to apply. So there are 7 funded research bases in the country. 2 of them are in academic cancer centers. One is my research base that I run, and the other one is at Wake Forest. Then there are 5 more that are affiliated with what are called National Cancer Institute treatment trial groups. Okay, and their focus is really different. But us in Wake Forest, we're kind of like those, believe it or not, the smaller boutique versions of those research bases, okay? So those would be the big dots, like the blue dot you saw where I am, they're not all on there. And then you went down to the red dots, those are NCORs, and in those NCORs, they are funded with a grant from NCI. And they have people all over that they work with. The spread of all those community oncology practices really leaves a void, as you can see, in the middle of the country. That's something that NCI in and of itself recognizes and has been trying to pay attention to and to change. But the other part is that also, and it's not fair, I'm not saying it's right, but it's also the most population devoid part of our country. So even though it's there, it's not where the majority of the population geographically resides. So there's not a lot of care there, and there's not a lot of oncologists who can go and get these grants in those positions or those places geographically. Definitely not right, definitely a hole, definitely a place that we need to try to figure out. I'm not choosing those sites. NCI chooses those sites, and then they affiliate with me as a research base. What I will say is that when I first started this work there, back in 2003, we were miserable at our low SES, underrepresented, underserved populations in terms of race, in terms of ethnicity, in terms of socioeconomic status, all of it. If you looked at our trials going and coming, they were predominantly Caucasian, very affluent individuals. In the almost 2 decades since I've been working there, NCI did revamp its program for the NCOR community affiliates. And now there are a total of, I just wrote this in my grant, there's a total of 46 NCORs funded around the country. Those 46 NCORs work with over 9,000 clinical investigators, 4,000 oncologists, like just oncologists who aren't clinical researchers, and 14 of them are in what are called underrepresented, underserved areas of the United States. So 14 of the NCORs, and then they have like hundreds of affiliated centers. So it's better than it used to be. It still doesn't cover everything. I wish it did. I do really wish it did. Because there are a lot of people who really aren't, they're not just not getting access to research. So my clinical network gives them access to clinical trials. If they're not accessing cancer treatment, period. It's very heartbreaking.
Because I'm thinking of people that I know from those areas that I believe could totally benefit from your program or like the research that you're doing.
Yep. I don't have any answers. I can't be in every state at all at the same time, but I wish we could. And people are paying attention. They're trying to push those networks. The National Cancer Centers Program, which creates NCI designated cancer centers, is actually paying big attention to that. And our cancer center is just submitting to get our NCI designation. And one of the things I learned about the 27 counties that we serve in upstate New York is that 14 of those counties are designated Appalachia per the federal guidelines. And nobody thinks of New York as having Appalachian counties. And we have 14 of them. Which is, you think of it in North Carolina, I know we talk about it all the time, right? But nobody thinks of New York as having that. Other questions?
I think, Karen, at this point, let's just take the questions outside. Lots of time still for question and answer, and so please stick around, and Karen will be there to continue to share her work and answer those questions. So thank you.
Thank you all. Thank you very much.